How do doctors stage cervical cancer? When it comes to understanding cervical cancer, one key aspect is how doctors stage it. Staging is crucial because it helps determine how far the cancer has spread in the body. This information is vital for planning the most effective treatment options. The staging process looks at how deeply the cancer has grown into the cervix, whether it has spread to nearby tissues or lymph nodes, and if it has reached distant organs. The most commonly used system for staging cervical cancer is the FIGO system, which stands for the International Federation of Gynecology and Obstetrics. This system categorizes cervical cancer from stage I, where the cancer is confined to the cervix, to stage IV, where the cancer has spread to distant organs. Each stage has subdivisions based on the size of the tumor and how far it has spread. Doctors typically use two main approaches to stage cervical cancer. The first is clinical staging, which is the primary method. This approach relies on physical examinations, biopsies, and imaging studies like computed tomography scans and magnetic resonance imaging. These tests help evaluate the tumor size, how deeply it has invaded, and whether there is any involvement of lymph nodes. Since an update to the FIGO system in 2018, imaging has become even more important for accurately assessing tumor spread. The second approach is pathologic staging, which is based on findings during surgery. This includes examining the removed tissue and lymph nodes. However, it is important to note that pathologic staging does not change the clinical stage and is often used when surgery is part of the treatment plan. The FIGO staging system breaks down as follows. Stage I is when cancer is confined to the cervix. Within this stage, there are subcategories. Stage IA indicates microscopic cancer with very small invasion depth. Stage IA1 means invasion is 3 mm deep or less, while stage IA2 indicates invasion greater than 3 mm but less than or equal to 5 mm deep. Stage IB refers to larger tumors that are still confined to the cervix, with subcategories based on tumor size. Stage II is when cancer has spread beyond the cervix but has not reached the pelvic wall or lower vagina. Stage IA indicates spread to the upper two-thirds of the vagina without affecting surrounding tissues, while stage IIB means there is spread to the surrounding tissues. Stage III indicates that cancer has spread to the pelvic wall or the lower third of the vagina, and it may also involve lymph nodes, which is classified as stage IIIC. Finally, stage IV is when cancer has spread beyond the pelvis or has affected the lining of the bladder or rectum. Doctors use a combination of physical exams, imaging tests, and biopsies to assign the stage of cervical cancer. Imaging techniques like magnetic resonance imaging, computed tomography, and positron emission tomography scans are essential for evaluating tumor size, lymph node involvement, and any distant metastases. The choice of imaging depends on what is available and the expertise of the medical team. Staging is not just a classification, it guides treatment decisions. Depending on the stage, treatment may include surgery, radiation, chemotherapy, or a combination of these. The stage of the cancer also helps predict prognosis and tailor therapy to maximize effectiveness while minimizing side effects. In summary, staging cervical cancer involves a detailed clinical evaluation and imaging to classify the extent of the cancer using the FIGO system. This process enables personalized treatment planning based on tumor size, local spread, and metastasis, aligning with current medical standards for managing reproductive cancers, including cervical cancer. Always consult healthcare professionals for personalized medical advice.